us online. It's my great pleasure today to introduce our grand round speaker, Dr. Kevin Herold. I've known Dr. Herold, it turns out, for 10 years now. We just figured it out. We met at the bedside. And I think for the fellows in the audience, this hopefully will be a teaching moment. Because you get a sick patient, you're not sure what's wrong with them, you call the expert, and from that we developed an entire universe of research projects, grants, and so on that Dr. Herold will be talking about today. To me, that exemplifies the beauty of Yale University and what we're about. Unusual clinical circumstances, taken back to the bench, going back to the clinic, et cetera, et cetera. But the best part of it all is the collegiality. So I'm just remembering after we got our funding, the very first research meeting that I had with Dr. Herold and Dr. Eric Meffrey, who's since left Yale. Now, I'm not an immunologist, but they both are card-carrying immunologists, and Dr. Meffrey in particular doesn't tolerate fools. So I was really intimidated by this meeting, and I had established ground rules. I don't know if Dr. Herold remembers this. We decided that this is an idiot-free zone. We're all smart, we can say whatever we like, and we never have to be embarrassed. And I think that principle has led us in the last 10 years, because it turns out that even I had something to bring to the table here. So collegiality, respect, creativity has led to a whole field that I think we've opened up here in translational research on immune-related adverse events for endocrine toxicities. So other than this whole world, Dr. Herold is actually really famous for delaying type 1 diabetes in kids. Major breakthrough in delivering CD3 antibodies to children who had started to develop type 1 diabetes, giving them the anti-CD3 antibody, delaying the onset of full-blown islet cell destruction. I don't think he's going to be talking about that today, but today we look forward to listening to all the cancer-related studies that he's done. So without further ado, thank you, Dr. Herold, for taking the time.
Okay, thank you very much, Harriet, for that very kind introduction. I have to admit, I was also quite pleased that we were going to set up our research meeting, so it would be an idiot-free zone. I appreciated that. Here's my disclosures. So hopefully this is review to everyone that basically we live in a constant immunologic equilibrium, balancing lymphocyte activation and control. And the activation is controlled by a number of co-stimulatory molecules and recognition by antigen, by T cells and other immune cells. And the major developments in the cancer field, of course, are that by disrupting this balance, we can develop effective ways of treating cancers. And indeed, this has revolutionized the field over the past decade. And it became very clear initially when these agents became available for clinical use that there were adverse events that would occur as well. Since the balance that prevents us from developing autoimmunity is controlled by these same mechanisms. And it's been established for many years that even normal patients have immune cells that are capable of recognizing self-antigens. So by tipping this balance, it's fairly clear that one would be able to develop autoimmune diseases. And that's what I'm going to be talking about today. Now, the endocrine organs seem to be particularly vulnerable to immune-related adverse events with biologic therapy, particularly with checkpoint inhibitors. And this is from a review that came out a number of years ago, but there are many, many organs that are affected. On the right side, we see just the endocrine organs that are affected. Thyroid disease is the most common and frankly can be over 15% in some series. The second most common is pituitary disease that can be difficult to diagnose, certainly important to diagnose. And then the other endocrine organs seem to be affected as well, including the insulin-producing beta cells that leads to the development of diabetes. Now, I would point out from this graph that that the development of these adverse events are most common with combination therapies. And this is going to come up again in some of the data I'm going to present to you, that the combination of anti-CTLA-4 plus anti-PD-1 or PD-L1 seems to be seems to impart a higher risk of developing these adverse events than either agent alone. So the timing of them varies a bit, and sometimes we, as a practical matter, have a hard time determining whether or not an adverse event that we may see is directly related to the checkpoint inhibitor that's been given, or whether it was just happening by chance. Because some of these adverse events, such as thyroid disease or diabetes, are relatively common in the population, particularly in the older population. But this graph shows you the timing of some of the more common adverse events. You can see that hypophysitis can happen several weeks after the development, after checkpoint inhibitors are administered. Some of the others that are also quite common tend to occur in a more acute manner. Now, as Harriet mentioned, we started, I'm going to spend most of my, the rest of the talk talking about checkpoint-induced autoimmune diabetes, because that's where we've done the most work. And let me just mention one thing about some of the others. You know, I do want to say sort of upfront that, that the mechanisms of some of these other checkpoint-induced endocrine adverse events are not very well worked out at all. There is really one sort of lead paper that described the development of autoimmune hypophysitis that talked about expression of CTLA-4 on pituitary cells and suggested that what happened with CTLA-4 is that the antibodies bound to CTLA-4 on the pituitary fixed complement and destroyed the cells. But if you go through the paper carefully, you'll see that, well, it really wasn't it wasn't the ACTH producing cells, which is a common manifestation of hypophysitis. It was prolactin producing cells and also TSH producing cells. So the precise mechanisms there really aren't quite so clear. Likewise, for thyroid disease, I think it's still somewhat of an unknown or a wide open area for investigation, I should say, to understand the mechanisms. But we focused our attention on autoimmune diabetes and hopefully have made some inroads into understanding the mechanisms here. And our work began, as I pointed out to Harriet, if you take a look at the date on this paper, almost a decade ago, when the patient number one here was referred to me by Dr. Kluger, and it was a woman with melanoma who had been treated with IPI and also had gotten nivolumab at that point, and presented with diabetic ketoacidosis. And, you know, this was quite striking. This is someone who's 55. And then subsequently, there were a number of other cases that came from Yale of people over the age of 50 who were presenting with ketoacidosis often and new onset hyperglycemia. And this was kind of striking. And to me, it was striking because you know, we hadn't seen it before. The anti-PD-1 drugs were new at that time, but we had had anti-CTLA-4 ipilimumab for a number of years. And so that was kind of striking. So we ended up putting these series together, and this, I know I mentioned this the last time I spoke, but I want to kind of bring this point up again, particularly for the trainees who are here. And the data that we've subsequently had even makes the point even further. So we put this series together and we sent it in. We sent it into the endocrine journals for publication. And you know, a lot of people, a lot of the journals, or some of the journals weren't interested in it. And then finally, it goes to one of the leading endocrine journals and gets sent out for review. And we get comments back from the review. And we did a very extensive job answering all the comments. There were 12 pages of responses. And so we sent it back. And the reviewer comes back and says, well, if if this was really occurring, the development of diabetes after anti-PD-1, we would have known about it already. So that was the end of that journal. So we ended up publishing this as a letter, actually, in Diabetes Care, and it is one of the most highly cited, certainly one of the most highly cited papers in Diabetes Care. That is the first description of anti-PD-1 antibodies. So the reason I wanted to mention this story to you is, as I'm going to show you later on, that not only was the reviewer wrong in saying that we would have known about it, but mechanistically now we know why the reviewer was wrong. So that's kind of nice to know why your reviewer is so wrong. So what are some of the features of this form of diabetes? So first of all, it happens relatively very acutely. Here's some data. This is coming from our colleagues at UCSF, where we've put together patients at the two institutions. And you can see this, here are a few patients who developed checkpoint-induced diabetes, and their blood sugars are completely normal. And then dramatically, there's a big spike in their glucose levels. And the other thing that's quite interesting about that is, if you look at their endogenous beta cell function by measuring C-peptide, remember C-peptide is cleaved from proinsulin when the beta cells make insulin, and it's a good measure of endogenous insulin production because the insulin you inject doesn't have C-peptide. So if you take a look at the kinetics of loss of C-peptide here, it happens very, very quickly. In fact, in one case, it happened while patients were following the individual, while investigators were following the individual in the hospital. And the other point about this is, patients generally go to 0 or near 0. In other words, levels that are clinically insufficient. We'll come back to that later on. Here's a few other bits of information about the demographics of patients. So you can see the age. These are people who are older than you might expect with presenting with diabetes. It generally occurs with anti-PD-1 or anti-PD-L1. The hemoglobin A1Cs are elevated, probably because of the degree of hyperglycemia. About half of the patients and depending on the review, an even higher percentage present with ketoacidosis. C-peptide frequently becomes undetectable. The median time is about 11 weeks, and only about 40% of individuals are positive for autoantibodies. And this brings up a classification issue. Some people call this type 1 diabetes. As I'm going to explain to you, I don't think this is type 1 diabetes. It's autoimmune diabetes induced by checkpoint inhibitors, but it's very different from classic spontaneous type 1 diabetes. Now, there is a very large proportion of individuals who we don't talk about a lot, who I think probably fall into this bucket, who are individuals who may have mild type 2 diabetes, who then present with much worsening of their glucose control, and may previously have been managed with oral anti-diabetic agents, and now all of a sudden may present in ketoacidosis or may require insulin therapy. Now, type 2 diabetes is a very common disease, so it may actually be that the frequency of this disease is much higher than is even represented by the 0.2 to 1.9% from the past reviews. Now, I mentioned not everybody has autoantibodies. Here are some examples of that. Some patients, if you take a look at 3 patients on the bottom, some start out negative. Each of those antibodies are one of the autoantibodies that we measure in classic type 1 diabetes. You can see some patients start out negative, become positive. Some patients start out positive, stay positive. So it varies. About 40% overall are positive, but the frequency of those who are positive, sorry, let me go back, for 2 or more, which is kind of the hallmark of spontaneous type 1 diabetes, is relatively low. Now, curiously, the alpha-producing cells in the islet, remember the islet is a collection of cells, alpha cells, beta cells, delta cells, and so on, that make a variety of hormones. The loss of endocrine cells seems to be limited to the beta cells. The alpha cells sitting right next to the beta cells are unaffected. And the reason for that is not clear, but as you can see from this data from patients that where we measure glucagon here, didn't seem to make a difference in terms of their glucagon levels. Now, one of the early striking findings from our series of patients was that a high proportion of individuals were HLA-DR4. Now, DR3 and 4 are associated with classic spontaneous type 1 diabetes, but this proportion of DR4 is strikingly high. And it's higher than the background population. And DR3, the other allele associated with spontaneous diabetes, was not increased in frequency. So DR4 somehow or another seems to be important in predisposing to the development of checkpoint-induced diabetes. And I want to point out this recent observation that was originally made by Jasmine Caulfield and Lilac Eisenbud from our patients here. And what was done is we were doing a genome sequencing of tumors and identified a number of mutations in a variety of genes that seem to be associated, what seemed to be at a higher frequency in people with checkpoint-induced diabetes. And then we ended up going back and doing sequencing of peripheral blood cells and finding that indeed there were germline mutations that seemed to be associated with development of checkpoint-induced diabetes. And interestingly, the highest frequency was in this molecule called NLRC5. And you can take a look on the right. The frequency of individuals with NLRC5 variants was in our series 65%. Now, it's not a huge series because we don't have tons of patients. We had 13 here, but you can see that at least statistically, it turns out to be in a much higher frequency compared to those individuals without checkpoint-induced diabetes who get the same checkpoint inhibitors. Now, what's the importance of NLRC5? So NLRC5 actually tends to is involved in class 1 MHC antigen presentation. I'll tell you about that in just a moment. But you can see that it seems to be an important molecule involved in responses in cancer patients. That methylation of NLRC5, reduced NLRC5, seems to be associated with impaired CTL activity and clearing of tumors. Its expression seems to be correlated with survival. And in diabetes, it's also been associated with beta cell antigen presentation and in the interferon response. So, for example, NLRC knockdown beta cells seem to have a decreased interferon-induced class 1 MHC expression and seems to be associated with protection from autoimmune diabetes. So NLRC5 is a regulator of class 1 dependent antigen presentation, much the same as the classic class 2 transactivator. It's responsible for bringing peptides into the endosome for processing and placing them on developing class 1 MHC molecules. Its expression seems to be induced by interferons, particularly interferon gamma through STAT1 signaling. This review actually describes the mechanism. I'm not going to go into detail about it, but what we ended up doing, and this is work that Anna Perdigato did, we ended up looking at expression of TAP1, which is an important transactivator that's associated with class 1 MHC expression, as well as HLA-A on peripheral blood cells in patients with the mutation or with wild type type of the NLRC5. And as you can see, and in patients with the mutant, there seems to be higher expression of TAP1 and actually of HLA-A, although we haven't reached statistical significance for the HLA molecule. So it suggests at least that there is some change in expression of MHC molecules or potentially presentation of peptides by individuals who have this mutant. So to summarize these 2 points, there seems to be evidence for mutations or differences in class 1 and class 2 MHC molecules that are associated with development of checkpoint-induced diabetes. First of all, HLA-DR4 is common, and perhaps that leads to the development of an autoreactive repertoire. This NLRC5 mutation also seems to have some role in potentially in expression of molecules, a presentation of molecules by beta cells, or even potentially in affecting a subgroup of CD8 positive T cells that have been associated with immune regulation. Now, let me just raise some questions about these 2 points by pointing this out. When we've looked at autoantigen reactive T cells in patients with checkpoint-induced diabetes, when we've looked for autoantigen reactive T cells that are reactive to conventional type 1 diabetes autoantigens, we don't really find an increase. So if you take a look at, we've looked at T cells that are identified by binding to class 1 MHC tetramers that are loaded with the peptides that are shown on the left side. If you look at the frequency of these cells on the right side, and the individuals treated with checkpoint inhibitors who don't have diabetes or do, there's really no difference. So it at least would suggest that the known autoantigens or recognition of the known autoantigens is not really increased, or at least the frequency of cells is not increased in those individuals who are developing checkpoint inhibitors. Let me just, sort of say as a preface to this data, the low-hanging fruit on this was, well, these individuals had an autoreactive repertoire. They had DR4. We removed the checkpoint blockade. These cells just did their thing. Don't think so. It could be that there are cells that are reactive to unknown autoantigens. And as I'll show you in just a moment, there is some evidence that that might be true. But that's not all. There's also evidence of inflammatory lesions or inflammation that's occurring in the pancreas that may be very important for development of checkpoint-induced diabetes. And this actually came from actually a clinical observation from patients here, in which we found that there was an increase in amylase and lipase in individuals who ultimately went on to develop diabetes. They don't develop clinical pancreatitis, but here we're looking at the amylase and lipase level on one individual who develops checkpoint-induced diabetes. And you can see the lipase on the left bumps, and then red is when they develop diabetes. And the amylase bumps, and then red is when they develop diabetes. If you look at our entire series, and look at the relative levels of lipase or amylase on the bottom, you can see that that both are elevated prior to the development of diabetes. Now, interestingly, it prompted us to look at what's actually happening in the pancreas. They were not symptomatic. And so we ended up looking at CT scans that fortunately we had from before and after individuals presented with diabetes. And what we found, if you take a look at the CTs and on the top here, is the red arrow identifies the pancreas. There actually seemed to be shrinkage of the pancreas in individuals who went on to develop checkpoint-induced diabetes. So it suggested that there is more than just a direct attack on beta cells, that there may actually be a broader attack in a broader inflammatory response in the pancreas. And unfortunately, one of our patients died soon after they had developed checkpoint-induced diabetes, but we had the opportunity to take a look at their pancreas by immunohistochemistry, and this is what we found. You can see that there are plenty of CD45 positive immune cells that are infiltrating the islets and that are infiltrating the pancreas. They are not just in the islets, and in fact, many of them are outside of the islets, as you can see by staining for insulin on the right. And there are both CD4 and CD8 positive cells. Chromogranin identifies the endocrine cells. They're infiltrating the islets and they're outside of the islets. And if you look at cytokines that are present in the pancreas, we find both interferon gamma and TNF. Interestingly, one of the other findings from this immunohistochemical analysis is PD-L1 was actually induced on beta cells and on the other endocrine cells in this patient who died with checkpoint-induced diabetes. Now, that's a little weird. We thought that PD-L1 was actually protective against diabetes. So what's going on here? So let me just make the point, and again, this is work that Anna Perdigado has done, that indeed inflammatory mediators, particularly gamma interferon, will induce PD-L1 on beta cells. There is an interferon response element in the promoter of PD-L1. And as you can see by looking by flow, interferon gamma, and this is human beta cells, interferon gamma and interferon gamma with TNF induce expression of PD-L1 on beta cells. And it seems to be dependent through signaling by gamma interferon, because if you give ruxolitinib to block JAK signaling through STAT1, you can inhibit the expression of PD-L1. Now, there was good evidence for the importance of PD-L1 in development of autoimmune diabetes, and most of this work came originally from Arlene Sharp. And the work that I'm showing on the left is from a paper of hers a number of, actually 20 years ago now, that showed if you knock PD-L1 out of this susceptible mouse strain, NOD, that the mice spontaneously develop diabetes at a very young age. And the histology is shown in the middle here. Furthermore, if you gave anti-CD3 antibody to mice that spontaneously developed diabetes and induced remission with the anti-CD3 antibody, if you gave anti-PD-1 or anti-PD-L1, this is work by Jeff Bluestone and Brian Fife on the right side, the mice immediately redeveloped diabetes. So this work suggested that PD-L1 had a critical role in maintaining non-development of diabetes in a susceptible host. And here are some additional studies from Arlene's lab that showed if you took wild-type cells, transferred them into a PD-L1 knockout or a wild-type host, if you put them into the knockout recipient, which is on the left side in the open circles, mice rapidly develop diabetes, whereas they didn't at the same rate if you put them into the wild-type recipient. And it also was shown in her work that the importance of PD-L1 was indeed on the islets, because if she transplanted PD-L1 deficient beta cells into either wild-type or knockout mice, which is shown on the right, the PD-L1 knockout islets were more rapidly killed compared to wild-type islets. So PD-L1 seems to have some unique features that's important in protecting against autoimmune diabetes. Now, we did some additional studies comparing anti-PD-L1 and anti-CTLA-4, because let me go back to that paper in that letter in 2015 and the comments from the reviewer that pointed out, well, if this was really important, we would have known about it. Well, that reviewer was completely wrong, because indeed, the only checkpoint inhibitor that was available prior to that time was anti-CTLA-4. And if you take a look at the mouse data here, and this has been reproduced in other labs, anti-CTLA-4 doesn't do this. Seems to be unique for anti-PD-L1. And so we did some studies to try to identify what's different about anti-PD-L1 and anti-CTLA-4 in induction of diabetes. And I'm going to go through the data fairly quickly. We did this by performing single-cell RNA-seq on infiltrating cells and islet cells from mice that had received either of these checkpoint inhibitors. And let me first point out that in the presence, when these susceptible mice, NOD mice, are given anti-CTLA-4, there are cells that infiltrate the islets. It's not that they don't develop insulitis. It's just that they don't develop diabetes. They don't go on and kill the beta cells. So first of all, when we look at immune cells that are infiltrating the islets, you can see there is a difference if you take a look at panel D in the MELD analysis. There's a difference in CD8 T cells that are infiltrating the islets when the mice are treated with anti-PD-L1 compared to anti-CTLA-4. And there are a number of genes that are differentially expressed, including some of the ones that you might expect, such as TBET, interferon gamma, granzyme B, and even PD-L1, as we would have predicted, as well as perforin. And the volcano plot showing you the differences in expression in the CD8 T cells is shown in the bottom. Now, what about the cells that are infiltrating the islet? Are they the same? Maybe they're different. And this is the data that we have to date. And unfortunately, I can't go into this in with more granularity, except to point out that, yes, they are different. They are not the same cells that are being driven to the islets with the two different checkpoint inhibitors. If you just take a look at the frequency of various clonotypes, you can see with anti-PD-L1 in mice that do develop diabetes, there seems to be a relative selection of particular clonotypes compared to the anti-CTLA-4 treated mice. Now, macrophages also seem to be different for reasons that we don't completely understand, but you can see that they express PD-L1. They themselves express PD-L1. They produce CXCL10, which is important in recruiting cells to the islets, as well as STAT1, indicating they've been looking at interferon gamma. And this is interesting because work from Emil Unanue lab had actually pointed out that these cells seem to be the critically important cells for initiating checkpoint-induced diabetes in this model. Now, in addition, there are changes in beta cells. I showed you already in humans that we found that there was induction of PD-L1 in human beta cells that were treated with interferon gamma. Indeed, if we looked at genes that are differentially expressed with interferon gamma, you can see that there are a whole lot of genes that have some immune response properties. Now, the reason that we think this is important is because when beta cells see inflammatory cytokines, they make a number of important immune ligands, such as CXCL9, CXCL10, important for recruiting cells to the islets, as well as increased expression of class 1 MHC. When we looked at, this again is with human cells, when we looked at other features of human islets exposed to gamma interferon, we found that actually there was induction of FAS, suggesting that indeed that cytokine might induce killing of beta cells. And if you take a look at in panel E, you can see that in the PD-L1 expressing cells, we find this morphology suggesting the cells are actually dying. And indeed, if we look at the percentage of dead beta cells in panel D, it is much higher with cells that are cultured with interferon gamma. Back to the mice now, when we look at beta cells in the mice, in situ, there are a number of differences in them, including the development of a unique subgroup of beta cells. If you take a look at panel C, The fate diagram here shows you two populations of beta cells. The standard beta cells that you can see in mice treated with anti-CTLA-4 or anti-PD-L1, and then this unique a cluster of beta cells that seems to be uniquely found in anti-PD-L1. The main beta cells express the same ligands that I just showed you with human beta cells. CXCL10, PD-L1, class 1 MHC goes up, STAT1 is signaling, and TRAIL is actually increased as well. But in the unique beta cells, there's also changes, including reduced expression of a number of the beta cell identity genes, such as NKX6.1, MAFA, of course, insulin and chromogranin. So it's what this finding suggests is work that we've done in other models of diabetes, that there is some pathway leading to beta cell survival in the presence of checkpoint inhibitors that seems to be turned on when these drugs are given. All right, so that's kind of where things are in terms of what's going on in the islet, how human beta cells respond similarly to inflammatory mediators. So what's the point of that? And what can we do about it? So let me point out that in follow-up work that we did to try to figure out, could we, based on this knowledge, stop the development of checkpoint-induced diabetes? We first tested whether anti-cytokine antibodies might be able to do that. And I've shown you already the critical role of interferon gamma and potentially TNF in development of checkpoint-induced diabetes, at least in mice, and evidence in humans that both of these cytokines were present in the pancreas of an individual who died with checkpoint-induced diabetes. What happens if you neutralize those cytokines? And you can see on the top here that if you gave the combination of interferon gamma and anti-TNF to mice treated with anti-PD-L1, you could indeed prevent the development of checkpoint-induced diabetes in the mice. Furthermore, if you blocked a little further downstream with a JAK inhibitor, and this is I'm sorry, this says JAK inhibitor 1, JAK inhibitor 2, and I should just mention this is an ongoing collaboration with folks at Pfizer and with two new JAK inhibitors, the identities of which we don't know, except we know they're different. But as you can see, JAK inhibitor 1 looks pretty good in terms of preventing the development of checkpoint-induced diabetes. So to summarize what I've just told you then, what we think is there's actually an inflammatory cycle that's going on between immune cells and beta cells that leads to the development of checkpoint-induced diabetes. In response to interferon gamma, beta cells in turn make a number of immune regulatory molecules that recruit other immune cells, activate immune cells, leads to increased production of inflammatory cytokines, particularly interferon gamma. It leads to expression of PD-L1. When you block PD-L1, you seem to block the stop signal in immune cells that otherwise would cause them to leave the islet. And the immune cells then are there in the islet and capable of going on and killing the insulin-producing cells. So, and killing beta cells. So is there anything we can take home from this in terms of treating patients? And let me just start by mentioning this patient that was, again, another letter in diabetes care that was treated in Switzerland. This is a patient who had presented with type 2 diabetes. And let me go back to a point I made earlier. Type 2 diabetes is a common disease. And so it follows that there are patients who are going to develop checkpoint-induced diabetes who already may have pre-existing type 2 diabetes. And that's the explanation I'm going to give you for this case report that appeared in the literature. So this is an individual with pre-existing type 2 diabetes, had much worsening glucose control, You can see with a hemoglobin A1C of 11.6%, but did have detectable beta cell function. The C-peptide was 993, which is, plenty respectable, and was also autoantibody positive. So they believe that this patient had immune-mediated diabetes. They gave the patient infliximab, the anti-TNF antibody. And as you can see, the glucoses improved, the hemoglobin A1C came down, and so that was seemed to be very impressive to those investigators. The patient had been treated with insulin, they stopped the insulin. Now, since we saw that, we've also treated a few patients here. And I want to mention this work that's been ongoing by Noam and Anna for treating patients here who've developed checkpoint-induced diabetes with infliximab. Let me show you two cases. This patient had a history of type 2 diabetes, like the previous one that I showed you, and presented with very, very high glucoses. The hemoglobin A1C in the past had been fairly reasonable, and the patient had not been treated with insulin. There was a bump in the amylase and lipase, just as I showed you in one of the first slides. And then the glucose became markedly elevated. And as you can see, the patient received 3 doses of infliximab. And if you take a look at the response curves, in terms of the C-peptide, it actually did seem to, these are random C-peptides, I should point out. The C-peptide did seem to improve after the patient was treated with infliximab, and the glucose was also better. Now, these are anecdotal. These are not performed in a rigorous endocrine setting where we're actually stimulating beta cell function. But nonetheless, I think from the patient's point of view, the fact that he was able to get off of insulin and his hemoglobin A1Cs were subsequently improve is clinically meaningful. Here's another case. This individual with metastatic melanoma was treated with Ipi and Nivo and had adverse events, including uveitis and diarrhea that had been treated with steroids, and hyperglycemia was noted at cycle 21. There was no prior history of diabetes in this patient, and previous hemoglobin A1Cs had been normal. This patient again presented with a very elevated hemoglobin A1C, and the glucose was also quite elevated. This patient did not have evidence of ketoacidosis, whereas the previous patient that I showed you did. And remember that ketoacidosis is a sign of substantial insulin deficiency. This patient was autoantibody negative. So here we're looking at the random C-peptide levels. One of them is stimulated, the last one, that was just done a few days ago, and the glucose levels. And you can see that the glucose did improve, probably with the medical care the patient received, but the C-peptide also seemed to be pretty substantial. This is markedly different than what I showed you in one of the first slides, where the C-peptides pretty much go to undetectable in the majority of patients who present with checkpoint-induced diabetes, and do so fairly rapidly. So to conclude, adverse events are not infrequent with checkpoint inhibitors. In fact, I would change that to say adverse events are common with checkpoint inhibitors. Most common is thyroid disease and hypophysitis, but diabetes also occurs in about 1% of checkpoint inhibitor treated patients. Now, one thing I should mention is for patients, and we see them thanks to all of you in our clinic, but for the patients, this is a difficult disease. I mean, it's a lot different when a 12-year-old presents with, it's not that the disease is easy for a 12-year-old, but it's even more cumbersome for a 65 or 75-year-old who now has become insulin deficient, completely dependent on exogenous insulin for maintaining metabolic control. So it is quite a burden for patients. So preventing the disease would obviously be would result in very significant improvements in quality of life. It's most common in patients treated with anti-PD-1 or anti-PD-L1 antibodies and in patients who are HLA-DR4. Still, a lot of work needs to go on to understand what is the significance of DR4 or the significance of NLRC5. But it nonetheless suggests that there is some change or some difference in these patients in presentation of either class 1 or class 2 or both. MHC presented antigens. Pancreatic inflammation is frequent prior to the development of checkpoint-induced diabetes. Curiously, PD-L1's expressed on beta cells. And I think we have to conclude that in spite of expressing PD-L1 on beta cells, and in spite of showing its extraordinary protective effect in animal models of disease, that when you give a checkpoint, when the checkpoint inhibitor is given, that protective blockade is gone, and even afterwards, PD-L1 expression is no longer able to stop the development of diabetes. And I think the identification of mechanisms have suggested a therapeutic strategy. Inhibition of inflammatory mediators may potentially halt progression of diabetes and beta cell loss with checkpoint-induced diabetes, and a short-acting inhibitor, potentially JAK inhibitors, would warrant some further testing. One last comment. Let me mention that, I think one of the interesting things about all of the checkpoint-induced adverse events is it a feature of the checkpoint inhibitor, a feature of the tissue, or a feature of the patients, or all three of these? And let me just point out this work from Jackie Mann in our group, who looked at checkpoint inhibitor-induced colitis. And she did this by single-cell RNA-seq. This work was published fairly recently, but let me point out that a number of the molecules that I just told you about being found in the pancreas of checkpoint-induced diabetes can also be found in patients who develop colitis, suggesting that we might even think about a broader use of various inhibitors, not inhibitors, obviously, that would prevent the anti-tumor effect of the checkpoint inhibitors, but might be given sequentially after the anti-tumor effects of the checkpoint inhibitors, and that might be rapidly tapered in the event that further cancer therapy is needed. So I'm going to close with that. I want to thank a number of individuals, particularly Harriet, who's been a colleague for a decade now, and a number of individuals in her group who've I've had the good fortune of working with as well. I want to mention Leilak's work on identifying the LNLRC5 mutations. I showed you some of Jackie's work. Noam is continuing this work particularly with giving with the NLRC5 mutations and therapies of checkpoint-induced diabetes. Anna Perdigado did actually all of the work, the single-cell work with the mouse models, and is continuing to go on to do that. And we have colleagues at UCSF and funding you can see on the right side here. So I'll stop there, and I'm happy to answer any questions.
Thank you, Kevin, for a wonderful presentation. Kurt.
Thank you for an excellent talk. I wanted to ask, so LNRC5 is a little bit kind of superficially counterintuitive in terms of germline mutation. I was wondering if there was a role in central tolerance and if you saw increased checkpoint inhibitor autoimmunity in hypophysitis or hypothyroidism.
I'm sorry, I missed the second part. I understood your question about central tolerance, but
so whether you saw, rather than NLRC5 mutations germline in just type 1 diabetes, or checkpoint inhibitor diabetes, or whether also in other.
I think that's still somewhat of an ongoing question. I think it's unlikely. Harriet may have a thought as to whether it's more likely.
Yeah, I can, well, Noam can answer it as well. So we have looked in at NLRC5 SNPs in other toxicities. It seems to be higher as well in hypophysitis, but not colitis. That's as far as we know so far.
But the statistics aren't,
They're not, this numbers are small still.
Yeah.
But that's exactly what Noam is working on right now.
That could make sense.
yeah, I mean, it could be. The only, so I think that's an interesting question. But you're taking us back to the original model. These patients had a repertoire ready to go. And look, it could be right. I mean, just because we don't see the usual suspects doesn't mean that there aren't suspects.
Kevin, that was an amazing lecture. It reminds me of 2015 or earlier when we first started using these agents, and we're seeing wonderful responses. And patients with lung cancers and others would have these problems, and they'd be on the throughout the hospital, and they wouldn't get the care they needed because no one recognized that these toxicities were part of this, even though they were benefiting from the therapy. I have a two-part question for you, and you now know who's at most risk. You have the NLR, other risk factors. So my first question would be, one, would you treat prophylactically, or would you wait until they develop the toxicity to start treating? And then the second would be, do you see that the activity against the cancer is increased in the patients that have these abnormalities?
Yeah, let me address the second question first, because there is some literature suggesting that those who develop these adverse events do better in terms of their anti-cancer activity. And indeed, our patients did well in general. But there is a publication for sure suggesting that those who develop hypophysitis had better outcomes in patients with melanoma. So I'm not certain, but I think it's certainly not a negative thing in terms of the cancer response. And it may, I mean, just because you don't develop toxicities doesn't mean you can't do well with checkpoint inhibitors. So in terms of when I would treat, if we knew how to treat autoimmune diabetes, if we knew what the antigens were, for example, we could dream about coming up with some sort of antigen-specific prophylactic therapy and give that before we give the checkpoint inhibitor. At this point, I don't think we have that. And so my suggestion would be to carefully follow patients, look for the signs that identify those who are at risk of developing it, and then when is appropriate in terms of the cancer therapy strategy, if it's possible, come in with some short-term inhibitor.
Thanks.
Thanks, Kevin. Dr. Weiner, and then Dr. Clark.
Just a great talk. Just a couple of simple questions. Are there gender differences in toxicity?
We, not that we had seen in diabetes, not significantly different. We saw-
Harriet looks puzzled why I would ask that. Only because autoimmune disease is so much more common is more common in women than men. Yeah.
We didn't find that. We've looked.
Yeah.
But there would be.
The only thing I can say is type 1 diabetes is not really general.
Right. No, I realize that.
Yeah,
Um,
but this isn't type 1 diabetes.
and this is for either of you. I mean, do you think that clinicians really have a sense of how abrupt the onset is of diabetes in this situation and are looking for it? I mean, because, it's happening not at week 2, it's happening at week 6 or 8. The presentation is very acute. I mean, there are some number of people out there, as these therapies are used more and more, who are going to die from this.
So there have been deaths, there will be deaths, where there isn't sufficient, there isn't sufficient insight. The 2 patients that we haven't showed where we were able to give the TNF, that was just chance. The first one was in hospital because of colitis or something else, and that's when they noticed the sugar going up. The second one is an EMT, and he noticed his own polydipsid proteinuria and started checking his glucose. But there's not sufficient awareness.
Yeah, but the other sort of take-home point from that is you need to be aware of this acutely, because I showed you the C-peptide levels. When it goes to 0, there's no turning back. So I think close surveillance was important. Yeah.
Well, I can tell you that I don't educate patients, to look for these kinds of things.
And just a quick, very, very interesting data. Two quick questions. One, for the germline NLCR5 mutations, you may have said this, but are those associated with standard classic autoimmune type 1 diabetes as well?
Yeah, there's there's that one paper from Detzio Eisrich suggesting that the answer is no, not really, not one of the important players. Nonetheless, though, seems to be important, and it can affect anagenicity and development of diabetes.
And did you go back? So you made the comment early that, the 40% of the patients who have autoantibodies to the islet cells, it was only 40% as opposed to all of them, and that was one of the reasons why this looked like this. One of your
Yeah.
conclusions why this was different than standard, type 1 diabetes. When you went back and you started looking at all these mechanisms in your patient population, did you look at the difference in those patients who had autoantibodies and those who did not?
Yeah, it's an interesting point. No, to my knowledge, I don't think we've done that. That's an interesting point.
Way to kind of
Yeah.
confirm this
Yeah.
this hypothesis.
Yeah.
We have a couple of online questions.
Oh,
here, or
okay,
comments.
okay.
That might be
Okay.
easy for you to look at it there.
Okay. Anna has a comment. It'd be helpful to monitor blood glucose more carefully in patients who have lipase elevation. And in some patients, there's mild elevation in glucose before severe presentation, so monitoring them more carefully may be valuable. That's yeah, a very good point. And then there's a question about racial differences in toxicity, not that I know of.
We don't have any-
Most, yeah, I think that's right. Most of our patients are Caucasian.
maybe more
Yeah.
time for two. Oh, what are we gonna do here? You see, you should have sent your paper to the New England Journal, to the Clinical Oncology, instead of the diabetes.
That's right. That's right.
That was an amazing talk. Thank you. I had a question about the lipase elevation occurring before the onset of diabetes as well. You showed that it's common that occurs, but did you look at patients that have lipase elevations and how often they develop diabetes? We don't routinely follow amylase and lipase in patients, but occasionally on clinical trials we are required to look at it, and so that it would be interesting to see, is it common that it is pre-occurring or
Yeah, that's a very good point. I don't believe we've done the analysis that way, unless Harriet or Noam, you or Anna, of doing it differently. It's an interesting approach.
because we
Usually a
often
lipase-
see elevated, or not often, but when we see elevated amylase or lipase and patients are asymptomatic, we don't really do anything about it. We
Right.
just watch them.
Right.
But if you knew that had a higher incidence of
Yeah.
leading to diabetes, maybe that's a population
point.
you could treat. Yes.
Hello. I'm relatively new to immunobiology, but I had a question about the slide where you showed the immunohistochemistry results, and you said that you saw signal or you saw staining outside of the islets. And I was wondering if you could further explain the significance on why you were excited about them being outside of the islets.
Oh, yeah, but look, I would have been more excited if they were inside the islets, but I think the point from that is that this is not just, there's a broader inflammatory response. And our assumption is that the islet cells can see the soluble mediators. So I think, we, at least in the type 1 diabetes field, we tend to think of, single T cell clone going into the islet, hitting a single target. And I think this is a bigger inflammatory response.
Thank you.
And I think that's why the lipase and amylase are elevated.
I have many questions, but I'll just ask. You had mentioned, or you had referred to the potential implication of regulatory CD8 T cells.
Yeah.
And was wondering, in your comparison between anti-PD-1, anti-CTLA-4 differences, did you see any
No.
differences?
Haven't seen it,
And then have you also?
but we're
do
going to
you-
look for it.
Do
Yeah.
you know if there are any differences in HLA-C allotypes or HLA-E or non-canonical MHC?
That's a good question, and not that I know of, but that certainly is something worth doing. EG and yeah,
For the curves, probably the C and E, I think.
yeah.
Kevin, thank you so much for a wonderful talk.